I'm Jason Karlawish from the University of Pennsylvania's AI Tech Collaboratory. And I'll be moderating this session on ethical artificial intelligence. And I will be introducing our speakers in just a moment in the order with which they'll be speaking. Irene, Chen, are you here? No, come on up. But before I do, the first federal report about Alzheimer's disease, published in 1987, was titled "Losing a Million Minds, Not Losing a Million Lives," and I think it nicely captured why Alzheimer's disease and other neurodegenerative diseases are diseases. The nature of their suffering is not that they cause you to lose your life, but they cause you to lose your mind, whatever that means. And mind matters. Things with a mind we take very seriously. We have an ethical obligation to support and empower, and things that we don't think have a mind, like this bottle of water, we can do things to, and we don't feel like we're ethically culpable about it. To have a mind means to have the ability to experience the world, enjoy music, enjoy food, and to act with intentions in the world, to act on your values. Mind isn't cognition. Babies have minds, even though they are not verbal. Teenagers have minds, even though their intentions are a little screwy. We could keep on going on that theme. But if you have a mind, you owe people respect. And so here we have this disease that takes away the mind in some way, whatever that means, some degree of experience, apropos the behavior question earlier, and takes away some capacity to act with intentions. And we bring technology to solve that problem. So I hope these introductory remarks sort of gin up the sort of ethical frisson that surrounds this work of technology, that it's actually providing mind support for people whose minds are damaged. And so it's with that introduction that I'm really proud to have and honored to have my three colleagues here to speak about the ethical issues. To lead off will be my friend and colleague, Emily Largent from the University of Pennsylvania. Emily co-leads the Ethics and Policy Core for the Penn AI Tech, along with Anna Wexler. Emily's a nurse, also trained in public policy, and her focus is on ethical issues that surround the biomarker transformation of neurodegenerative diseases, with particular attention to how that impacts on the dyad of the patient and their mind supporter, otherwise known as the caregiver. She's been a leader in advancing the concept of supported decision-making as a way to address that aspect of mind support. Following Emily will be Dr. Debra Mathews, who's Assistant Director for Science Programs at the Hopkins Berman Institute for Bioethics and an Associate Professor in the Department of Genetic Medicine at the Hopkins School of Medicine. She's a human geneticist by training and now does work in ethics and policy. She has a particular interest in emerging biotechnologies, particularly genetics, stem cells, neuroscience, and synthetic biology. She's the appointed president-elect now of the International Neuroethics Society. And that society focuses on complex ethical issues at the intersections between neuroscience and ethics and society. And then Dr. Irene Chen. She's wrapping up a postdoc at Microsoft. That must be quite exciting. And then this summer, she'll start up as an assistant professor at UC Berkeley and UCSF in their computational precision health program, where she'll continue her work on machine learning for equitable health. So a great panel. Each one has about 15 minutes to speak, and then we'll open it up for questions and answers. So if I may start, Emily, take it away.
Welcome, everyone. It's great to be here. I'm actually going to start off by talking a bit about algorithmic identification of dementia. This has been an issue that's come up. It's been in proposals we've seen in other areas of research, right? If people are interested in improving the lives of people living with dementia, you have to find those individuals. And so algorithms have been something that's of growing interest, people both seeking to identify and develop algorithms that are quite good at this, but then also using those algorithms to recruit participants or improve clinical care. So I'll be talking about some of the issues that arise there. So quickly, I'll just provide background on missed and delayed dementia diagnoses and talk about the implications of that for research, some level setting. I'll discuss identification of people living with dementia and highlight 6 ethical challenges that are associated with that. So it's really important to realize that a dementia diagnosis is often missed. Right, so approximately 40% of people with probable dementia go undiagnosed. And even amongst those who have a diagnosis, about 20% of them are unaware that they have that diagnosis. We have to realize there are a lot of people that we're missing in the healthcare system. And this is because older adults lack access to care or they face barriers when they seek that care. That can include structural gaps. So we know that memory centers tend not to be as readily accessible for rural older adults. We know that where these centers are located is patterned in the sense that sometimes there are minoritized communities that have a harder time reaching those centers. And even when you can get to that center, there can be formidable financial barriers. So even for people who are insured with Medicare, out-of-pocket costs can be such that they do not seek that kind of care. Now, even when individuals are able to access care, they get themselves in front of a clinician. There are clinician level barriers to diagnosis. These include the complex nature of the workup. Clinicians often suggest that they don't have confidence or enough time to conduct these. There's significant stigma associated with dementia, right? People have negative views about you. This can spill over to the caregiver. People have negative views about them, and it can be internalized, so self-stigma can occur. And I will be coming back to this theme of stigma quite a lot throughout my remarks. I think it's key to understanding some of the ethical dimensions we're discussing. And then there's a perceived diagnostic futility. I could diagnose dementia, but why? What are we actually going to do for it? And hopefully all of you in this room are feeling very motivated to come up with the why. Why is it not futile to identify people so that we can connect them with services and supports? The other thing that happens is that dementia diagnosis is often delayed, and this is where we really see a lot of inequities emerge. So patients diagnosed earlier in the disease course tend to be wealthier and whiter, more educated, and those diagnosed later in the disease course tend to be less affluent, racialized, and oftentimes rural. Again, for those barriers to access to care, it can take longer just to get into the clinic and get a diagnosis. The other thing that's important to all of us, right, is that if we think about those healthcare encounters as being a place where we see the genesis of data, the former group, right, those diagnosed earlier, are more likely to have more extensive data on follow-up care than the latter group, just because they're being seen earlier and then there are more visits. So all of this clinical background that I've just discussed really does have implications for researchers. When researchers seek to identify people living with dementia for recruitment into dementia-related research, they often go into Epic and they search on things like billing codes, right? What's the code for assessment of and care planning for cognitive impairment? Or they look at diagnostic codes. So if you go in and you put in your ICD-9 or 10 diagnosis code for Alzheimer's disease, or they look for medications that are prescribed for a diagnosis of dementia. So is somebody getting cholinesterase inhibitors? I will say that for those of us who are interested in neuropsychiatric testing, this is often not included in these various searches because not everybody has the testing, and so it can be quite difficult to do. So it really is these 3 that we see most often. But because of all the factors that I've discussed thus far, when you use these sorts of search terms to identify people living with dementia, the list is going to be shorter than it should be, right? Because you have all these people who have misdiagnoses. They have no billing code. They have no diagnostic code. They're not getting medication. And individuals on the list are not going to be representative because the people who are on that list are going to be those wealthier, whiter, more educated older adults who got in sooner. There's more data there for them. So healthcare systems and researchers are increasingly using algorithms so that they can facilitate the rapid real-time identification of people living with dementia. And I'm going to focus on the research aspects of this, but I think a lot of the issues hold too if you're a healthcare system or if you're somebody who's just looking to identify people for clinical care purposes. So one of the things, right, I talked about the basic algorithms that we have, and this is for detected dementia, right? We're finding people who already have entered the care system with a diagnosis or have been diagnosed with dementia. But even more exciting is this idea that we can find people who have undetected dementia, right? How do we find those people who haven't yet been diagnosed because it's been missed or delayed? And so here what we do is we're not using those things that are very directly linked to a diagnosis. Instead, we're doing things, we're looking and searching on things that are associated with a dementia diagnosis. So you can start looking for dementia-related risk factors like age or sex. You can look at dementia-related symptoms like psychosis or being underweight. And you can also look at healthcare utilization patterns. So for medications that are often prescribed to people with dementia, but not because of their dementia diagnosis. Right, so here we're talking, and hopefully you can all see and feel the potential of being able to find people who the healthcare system has so far missed by using these things that are associated. And I would say that the use of these detection algorithms in the context of research is really motivated by important goals. We know that research is essential to reduce or close evidentiary gaps. So far, we have to acknowledge that studies of people living with dementia have often been small, short-term studies. And this is an opportunity to hopefully start to engage in larger studies, long-term studies, and do a lot of things. But the use of these algorithms, while very promising, also does raise ethical concerns. And I'm going to just at a very high level with the time I have left highlight what some of those are. So the first thing is that when you're using an algorithm to identify people, you're creating new, private, identifiable information. I say new because, again, in the context of undetected dementia, you've now taken somebody who for, they did not have the sense that this was something, a label that was affixed to them. It's private because of the way it affects interpersonal relationships, all facets of your life, and certainly the stigma associated with it. And it's identifiable because the goal of the algorithm is to be able to link back to an individual, right? So we have this creation, and keep this in mind, this is an anchor point for a lot of the things I'm bringing up, that we are generating this new, private, identifiable information. When we're identifying people for clinical purposes, the goal is to provide some sort of direct benefit to them. But when we're identifying people for research purposes, the goal is actually to generate knowledge to help other people in the future, other patients. And so we're generating knowledge for the benefit of others. And we have to ask ourselves whether that goal can be reconciled with a patient's best interest. And that really is going to depend very much on the purposes for which the algorithm's being used and the way the study subsequently is being conducted. A third concern that comes up a lot here is consent to identification. I'm going to set aside for now issues that always come up that I want to flag for everyone in terms of people who maybe lack decision-making capacity and how we get consent in those cases. But here, algorithms that use existing data often are being used without any sort of consent from the patient or the caregiver. And we might not be as concerned if we're using the data that's very directly related to, say, diagnosis or care of dementia, because people have maybe, in theory, given some sort of consent for that kind of care related to their memory. But when we start using things that are associated with, people might not have a sense they have a dementia diagnosis, they've never consented to any sort of memory care, and now we're creating this new identifiable private information that maybe they have no sense that their encounters have been related to this. We also have to think about social value, equity, and justice. And I know that my fellow panelists will be talking about some of these issues in their presentations, so I'll speak about this briefly. The social value here is clear. We have to come up with better solutions for people living with dementia and their caregivers. But if we aren't careful and thoughtful about how we design these algorithms, when we're using information that's based on a patterned, unjust healthcare system, we are going to risk replicating those injustices in the research that we conduct. And so if we aren't designing intentionally for equity, we will be perpetuating inequity. We have to think about reasonable risks, right? And so often in research, we think about the risks of the procedures, the interventions, but I want you to think that the risk starts arising in the context of using the algorithm. And that's because in generating this information, we've risked exposing people to stigma and discrimination that maybe they haven't been experiencing subsequently. For people who are incorrectly identified, again, these associations don't mean that we have perfect, opportunities to find people. There's a risk of psychosocial harm if they're exposed to this, stigma, or actions that are undertaken under mistaken beliefs. And for people who are correctly identified, we have to be worried about risks associated with a loss of confidentiality, and we really do need to take steps to protect that information. And finally, I want to raise the issue of ethical communication. So you've generated your list of people with this algorithm, but now what? How do you reach out to them appropriately? So there's a real risk here that you risk cold calling somebody who doesn't have this information yet about themselves. So imagine opening up your email and saying that somebody would like to recruit you for a study of people living with dementia, but you've never been diagnosed with dementia. So now you have very sensitive medical information that's just been disclosed to you by somebody that you've never met, who's not a trusted source of healthcare information. And we can imagine that this undermines trust in research. It potentially undermines trust in healthcare. There are a lot of challenges we have to arise there. At the same time, once you've used an algorithm like this to reach out to somebody, we don't want to deceive them. We don't want to lie about the purposes for why we've reached out to them. So this is a really difficult needle to thread. And I'll say that I've spent a lot of time talking with investigators about how we can have this kind of outreach that's done in a thoughtful way. So fortunately, once we identify the ethical issues that arise and we think about sources of vulnerability, particularly for these older adults who are living with dementia, it's possible to design your study in ways that mitigate or even avoid some of these harms. So when we think, for example, about the use of algorithms, we can keep the results in a research record rather than putting it in a clinical record. I certainly wouldn't encourage anybody to put these sorts of algorithmic identification on somebody's chart. We can thoughtfully design outreach materials to avoid the problem of cold calling, or we could use the algorithm to generate a score and then treat that as administrative rather than diagnostic. So you might actually flag somebody for follow-up, have them come into the clinic, and when you confirm or give them that diagnosis of dementia, then you could start to recruit them into research. So we can think about all of this, but of course the solutions are highly dependent on the nature of the study that you're designing. Okay. So in conclusion, identifying people who are living with dementia is an important research goal, but researchers have to be mindful about the ways they're doing it because of the fact that this is a disease of autonomy, because of the fact that we have concerns about capacity, and because of the fact that society continues to stigmatize people living with dementia. And so this information has to be handled very carefully. Thanks so much.
Great. So Emily sort of set the stage for one kind of application of AI in this community or in this population of folks and the ethical issues that are raised or might be raised there. I'm going to sort of go up higher, 30,000 foot view, and talk about some of the broader ethical challenges raised by AI generally and in this context. So we can think about sort of as we design, develop, deploy these technologies in this space and elsewhere, what are the things we need to be thinking about? So you've already heard about a bunch of opportunities for AI in this space, and I imagine you're going to continue to hear about really exciting opportunities for the deployment of AI in elder care throughout the day, right? Improved detection, diagnosis, and treatment, harnessing this technology to enhance human well-being, using it to actually detect bias, enabling correction, using it to improve equity, for example, through access to care. But there are lots of challenges, right? So in broad challenges related to AI specifically, I mean, there are always challenges associated with the development of new technology. As was said, I work across a number of different technologies. I try to think of each new technology as an opportunity to sort of get it right, the deployment and develop and use of these new technologies. But it's always the case that the science moves faster than the governance or the ethical norms. Right, so that's general. But in AI, there are some additional challenges that are relatively specific to the technology, including the scale, the pervasiveness, and the invisibility of it, the degree to which it is starting to underlie many activities across many areas of life. Ethics is encoded into AI. It is, regardless of whether that's intentional or not, right? And we can be thoughtful about it and say, okay, what are the values we're gonna bake into this technology? But that's often not what happens. Often what happens is the ethics just get it sort of inadvertently baked into the technology. And it's worth saying that the folks baking in are not the most diverse group of folks in the world. So that's a particular ethical lens that's getting baked into the technology. And there are lots of ways that this can happen. So probably biased training data is the one that everyone's familiar with. Like, we know that the humans generated the data, humans are biased and sexist and racist. And so that's in the data. And those are the data that the AI are being trained on. There can be inappropriate labeling. So the thing that we don't have a way to label exactly what the technology is supposed to be striving for, but we have labels for that. So for example, future healthcare needs being labeled as future healthcare costs, right? Or credit worthiness being based on income, where we know that those proxies are all deeply structurally unjust in our society. So that bakes in problems. Narrow or inadequate functionality, right? The Apple Watch initially didn't have a menstruation tracker. That's half of the world that menstruates. So that was a bit of a miss there, although now it's fraught in all sorts of other ways. And then fairness or not associated with this. Also AI with, certain AI models, concerns about black box reasoning. Like it's not explainable. We don't actually know how the decisions are being made, making it difficult to detect problems. So one of the first things I learned from my AI colleagues when I moved into this space is this is the first thing they think of when they think of AI ethics, right? Asimov published these first 3 rules in 1950 in a story. Science fiction is really important in this field. And one of the teams I work with, these rules are actually painted on their wall. So this is interesting and sort of foundational in the field, but of course it's not comprehensive. These are not the laws that we can use to implement AI in people's homes. And also these rules are generally around or are structured around generalized intelligence. And I'm not going to be focusing on like Westworld. I'm going to be focusing more on AI as tools of the sort that have been talked about today and will be talked about later today. So there are all sorts of familiar ethical challenges in AI. These include informed consent, which was already alluded to, informed consent, not only for the individual who the system is being deployed to help, but also all of the people in that environment, if it's ambient or sensor-based AI. Concerns about privacy in that context, and privacy of the data being used, as again, Emily alluded to, going into charts to identify people with dementia in advance of them actually being diagnosed. Incidental findings, meaning you're going in to look for something, but you see a signal and you detect something that you weren't anticipating, and how do you communicate that? And that issue, we've actually been struggling with that in genetics for quite some time, right? Like we looked at your genome, we were interested in this one thing, but oh, look, we found this other thing, but we didn't tell you that that might happen in advance. So now we have to call you and say, so we found something in your genome and we can't tell you what it is, but do you want to know what it is? Like, that's an impossible conversation to have, right? So, concerns about data ownership and sharing. This is a big focus of discussion in genetics right now, but also in AI. And part of this comes out of some of the structural challenges that I'll get to in just a second. But going back to the whether you bake ethics in and whose ethics it is that gets baked in, right? There's an example of the fair and care principles that I like to use to explain to folks how sort of different sets of values shape governance differently, right? So the sort of set of scientific principles that are ideal for governing data sharing right now are the FAIR principles: findable, accessible, interoperable, and reusable. And that's really important to scientists, and it helps science move forward and ensures that we can replicate experiments and et cetera, et cetera. But a different set of principles that were developed by Indigenous folks in the US and globally are the CARE principles, right? Which stands for collective benefit, authority to control, responsibility, and ethics. And you can imagine that 2 systems for governing data sharing and use shaped by these 2 sets of principles would be very different. Right, so we need to think carefully about whose principles are shaping what we do in this space. Another familiar issue is dual use, right? These technologies can be used for health promotion. They can also be used for surveillance and discrimination. And historically, those are the benefits go to wealthy whiter populations, and the surveillance and discrimination go to marginalized and minoritized populations. And then the impact of early public failure. And I'm not saying ChatGPT is a failure. I'm just saying some pretty crazy things went down, right? And the general public knows about those pretty crazy things, and it is likely to have shaped their perceptions. And then I had alluded to these sort of contextual or structural challenges into which AI is coming, right? We are living in, as Shoshana just blinked on her, Hoffman, in an era of surveillance capitalism, right? Everything we're doing is being tracked. All our data is being hoovered up and being used in various ways, some of which benefit us, some of which don't. We've gotten quite used to click wrap, right? Where the terms and conditions are, I don't know, 120 pages long and written by lawyers, and you get a little checkbox and you say, yeah, I read that, I consented to that. I don't know what that was, but probably my firstborn, but okay, I really want the thing. And AI can do things faster, cheaper, and at scale, which is amazing and has potential benefits. But if what it's doing faster and cheaper and at scale is racism and sexism and all the other biases that humans have, then that's problematic, right? Because you're going to exacerbate existing inequities. And then in the context of healthcare, right, the impact on the therapeutic alliance, right? If you're substituting that trusted care partner with an AI system, what does that do to that relationship? AI can't care, right, in a way the human can care. And then finally, our brains really want to see agency and emotion, right? People talk to, I hope this doesn't activate your phone, Siri and Alexa, and ChatGPT in really conversational ways, and develop attachments and see agency there that isn't necessarily there. We know that's going to happen. Our brains are tuned to see that. So we need to be quite careful with that. And again, in elder care settings, then again, Emily alluded to concerns about consent and capacity to consent. Pre-symptomatic testing, if people aren't actually having symptoms yet, but there are biomarkers that indicate that you found in the medical record, for example, not everybody wants to know that, right? So it's not just the conversation, we found something, do you want to know? But oftentimes people don't want to know quite yet. Right? I've done a lot of work in Huntington's disease. Most people who have a risk of Huntington's disease in their family don't want to know. We've had a pre-symptomatic genetic test for that for decades. Most people don't want to know. And then concerns about companionship. Again, the use of AI for companionship. Again, going back to what I just said about we see agency, we see relationship, but you can't actually have a relationship with an AI. And then thinking about how we sort of bake our principles into governance, going back to my example of fair versus care principles, right? Like everybody has come up with a set of principles that should be governing AI. But there are many, many such documents. Here's one from the Future of Life Institute, the Partnership on AI Tenants. And these are great and important. These efforts are important. And there's often quite a lot in common. So there's this great paper from Anna Jobin and colleagues from a few years ago now, where they looked at all of these documents to identify what are the common ethical principles that are being espoused by all of these groups trying to develop guiding principles. And these are the common principles. The tricky bit is nobody defines them the same. And the different groups sort of, these principles adhere to different people or different groups. So it's not clear exactly what each of these means and whose responsibility it is to execute them in which part of the process. So we still have quite a lot of work to do. But the questions that I want us to keep in mind and want you to keep in mind as you go through the rest of the day are, what are the appropriate roles for these systems in this context? Who should decide that? How do we decide? Whose values should guide our decision making, and how do we meaningfully integrate values into governance? Thank you.
Thank you both to Emily and Deborah. That was very, I mean, as someone who works in this field, it's still always lovely to learn more about the different perspectives. I noticed that the two of them focused a lot on, you have this AI tool and we're going to, how are you going to use it? What are the downstream implications, and also what are the upstream ways in which it came to the be. Today, I'd like to talk a little bit about how we can open the black box of AI and think about how the choices that you make in the machine learning model itself have these downstream implications or can be taken into consideration upstream considerations. I'd like to thank all of my collaborators. It's being cut off by the Zoom, but that's totally fine, without whom all this research would not be possible. Yes, so I don't need to belabor this point. Machine learning for healthcare has an incredible wealth of opportunity these days. For example, the wealth of data available it seems to multiply every day, both in terms of modality as well as the scope and the size that we're dealing with. I particularly work on electronic medical records, but you could think of a lot of the principles that I talk about today as applying to many different kinds of data sets. And with all this data, we are marching towards a world where we have more and more even FDA-approved AI and ML-enabled medical devices. This is the latest graph that I could find all the way through 2021, but as you can see from this very clear power law, we can extrapolate and think about all of the different ways that AI and ML tools are entering our lives. However, machine learning for healthcare is challenging. I don't need to tell anyone in this room more than once, for a variety of reasons. I'm going to touch on three that I think will have a salient impact on some of my later points. One of them is that the fact that the data itself can be limited and sparse. I just said there's a lot of data. I just said there's a lot of opportunity, but I'm sure that many of you in this auditorium have found once you narrow it down to the actual subset that you're interested in, it turns out it's less than you wanted. It's yielding less information. And also people aren't maybe coming in to the medical system, or people aren't engaging with your data collection process as robustly as you had anticipated. There's also this concept of treatment variation. And what I mean by that is that different patients, even if they have the same symptoms or the same problems, maybe end up treated differently by the healthcare system. They may have different doctors who have more conservative or aggressive approaches, or they may have different preferences about what treatment they receive. All of these different ways that we treat patients can be quite tricky to deal with in large medical data sets. And then the last one is that healthcare knowledge changes over time. We are learning more and more every day. And in fact, in the New England Journal of Medicine, sort of a meta review saw that 13% of the medical practice papers are in fact reversals, meaning they contradict existing known medical knowledge. So machine learning for healthcare, not so easy. My research focuses on machine learning for equitable healthcare. And when we start to dig into that, it becomes even more tricky. One of them is that the healthcare system as it currently exists is already rife with health disparities. It is not equitable. As a very notable example, there's extensive research about the racial differences in maternal morbidity and mortalities. The New York Times has a great report about it, even just last month, where they really break down the different socioeconomic factors and show that even controlling for socioeconomic factors, there's a huge racial disparity. This is exacerbated by the fact that our data collection process is quite tricky. In genome-wide association studies, so these are so-called large data sets that are meant to encapsulate population health, a recent work found that 96% of the participants are of European descent. This was in 2009. Since then, they've really worked on it, and now only 80% of participants in GWAS data sets are of European descent. And the reason all of this starts to matter is that subpopulations can face differences in data distributions. What I mean by that is that one population may encounter health conditions in a different way, respond to different treatments compared to another population. If you're not measuring enough data to be able to figure that out, is it any wonder that we end up with disparate healthcare system? Oh yes, biased systems, biased data sets. Is it any wonder we have any algorithmic bias? Today in the, I guess 10-minute whirlwind, I'd like to walk through different examples of how all of these factors can affect the machine learning pipeline. As I mentioned, once you have a machine learning tool, they're great. There's all kinds of problems about how do you use it. There's all kinds of problems about how you got there in the first place. But even in the machine learning development process, there are a lot of decisions that you can make. And I'd like to talk through sort of considerations as you yourselves build your own AI tools. One is that the problem that you select itself may in fact be driven by many different considerations. So one of my projects that I work on is on intimate partner violence, domestic violence. As a fun fact, our studies show that we do very poorly on older populations because the way that it manifests is not as clear and is not as obvious compared to younger populations. Specifically, we took radiology reports. So this is a picture of a ulna fracture, which is one of the big warning signs because unlike, people will come in and say that they fell and they broke their, they broke their ulna as a result of falling, when in fact you would fall and break your wrist instead. And the ulnar fracture is much more likely to be a defensive wound. We developed an algorithm that can predict 3 years in advance of a patient self-disclosure saying, oh, actually, I do have intimate partner violence. I am a victim. I would like some help in order to be able to learn these signs. However, as I mentioned, that we want to make sure that this algorithm that we've selected because of the existing health disparities is able to be, I guess, taking care of the whole representative population. So the problem selection, what you choose to work on, matters itself. Once you've decided what problem to work on, how you collect the data has a lot of nuance. For example, one of the things that I often find in my work is that people don't even collect the group variable. People don't even collect race because they say, oh, we're not collecting race, therefore our data set is not biased. Any model that we build on it is not going to be biased as a result, because we're not even using race, it doesn't go into the model at all. This is incredibly difficult, one, because you cannot audit it, and also that is not true at all. There might be many features that are correlated with that race variable, with the gender variable, with a socioeconomic status variable that you are in fact still putting into the model, but now you can't even tell what's going on. Similarly, data can be imbalanced. That does not represent the population that you would like to use the tool on. As an example, an acute kidney injury model that created a lot of traction. Only 6% of the data set was women, which is a huge problem considering that is not at all the population that you would be using that model on. So you've collected the data. Now you want to set up your machine learning problem. Traditionally in supervised learning, you have your X variables, which is all the features you have about your patient or your person, each individual. And then you have the Y variable, what you would like to predict. A lot of times we focus a lot on X, making sure we collect as much X as possible. And we assume that the Y will be very obvious. In fact, researchers have found that choosing that Y is itself potentially fraught. In a study in 2019, published in Science magazine or Science journal, researchers found that there was in fact racial bias in an algorithm used by health insurance companies for care management. Let's go into a little bit what happened here. So here on the X-axis, we have the risk score that they gave, sort of if someone was going to need a lot of help, should they be allocated extra care management? And on the Y-axis is the number of chronic conditions. The yellow curve is the white population, and the sort of purple curve is the Black population. And in fact, what we see is that people who are the white patients were getting much higher scores for much higher scores for the same number of chronic conditions compared to the Black patients. And meaning that a Black patient would have to be much sicker to receive the same score. And the reason, let's dig into why. Let's not get into all of the math, but essentially the reason is that the label that they chose, this Y variable, was in fact cost and not outcome. They said, oh, insurance companies, we're an insurance company, we want to know who is going to cost us a lot next year, and we'll give more care to them. And it turns out healthcare cost in this country is incredibly fraught with a bunch of different confounding factors, and results in this racial disparity of this algorithmic model. And in fact, they were able to retrain the model using health outcomes. So are you going to have a medical incident? Are you going to have an adverse event? And through retraining the model on that, saw the racial gap close. So 2 more to go, just keeping an eye on the time. So now we have our X's. We're pretty sure maybe those aren't biased. We have our Y's. Those are probably fine. Let's throw it into a model. Finally, we can learn our model. We can develop our algorithm. What we find is that the model choice tends to have a lot of factors as well. Here's a case study from recidivism. So this is a bit outside the health space. Recidivism is the task of predicting who will recommit a crime in order to allow things like bail or early release. And on the left-hand side, we have sort of on the x-axis, we have the score. And on the y-axis is the actual probability that they end up recidivating. So they end up committing another crime. And what we find is that when you look at a model from one angle, so this is calibration, compared to on the right-hand side, it's false positive rate. There are different considerations that you'd want. And in fact, there's a mathematical theorem that says, you can't have a model that's both calibrated and has equal false positive rate when there are different groups with different base rates. Meaning if you choose a model, you're going to have to trade off between different notions of fairness. This is deeply unsatisfying as a researcher, but it in fact becomes a consideration that we have to talk through with clinicians and health practitioners to figure out what our model should be. As our panelists have also noted, access to care comes up a lot. In a different project, I've looked at how we can learn when people came into the system to make sure that we're not biasing towards people who are already coming in often and therefore are being able to be seen much more often. So these are all factors we can build into the algorithm itself. All right, last step. We've built an algorithm. We're pretty sure we're okay. How do we go about auditing it for bias? So this is probably maybe something that most people in the audience are more familiar with. Can I go back? Yes. So the reason I like to save this for the very end is 1, it comes at the very end of a long model development pipeline. And 2, this is what a lot of people think of when they think of algorithmic bias, algorithmic auditing, which is that there may be differences based on race, based on other sensitive attributes for an algorithm. On the left-hand side, we have results from a face detection algorithm. Researchers found that darker female faces had poorer accuracy for all of these off-the-shelf face detection algorithms compared to any other cross-section of these of sort of lighter, darker male-female faces. On the right-hand side, we have a ProPublica article about this recidivism case that I just talked about. And what each of these examples show is that, there's this model that existed, was making high stakes decision. Someone exposed them for saying, oh, this is actually racist, this is not okay. And therefore, as a result, they enforced change. The problem is, and we also find that in healthcare as well. So dermatology algorithms that are trained primarily on fair skinned patients don't do as well as darker skinned patients. And then similarly, this care management algorithm case study that I just outlined. The problem is that we find these audits and then we expose them. We sort of say, we tell the New York Times, everyone gets really upset. The question though is or maybe you run your own algorithm audit on your own, to make sure, to preempt any attacks or any surprises. And then the question becomes, now what? So why is your algorithm unfair? This is sort of if I could sort of impress upon everyone in the audience, one last thing, it's that you should be yes, there's potentially a gap. What's going on and how would we go about fixing that? So let's say we have group A and group B, and there's a difference in error. We call that a disparate impact of the algorithm. There might be a few different reasons, and drawing from statistics, we can actually start to think, group B might be a bit smaller. That's why the error is much higher. Maybe that's causing all of it. It could be that group B has more patterns and you need more complex computational tools. Think you need to bring out a nonlinear model for a linear data set or vice versa. And then lastly, measurements from group B might be less reliable. There's sort of all kinds of different possible explanations. In statistics, these line very nicely with variance, statistical bias and noise, which are things that we have sort of tied together with these definitions of algorithmic bias in order to determine the best possible fix. So if you ask, why is your model having this algorithmic audit situation, then you can start to analyze how to fix it. I'm going to skip this because I think we're running a long time. So I think sort of to close, I'd like to challenge everyone in the audience to think a little bit about where in this model pipeline do you think potential bias might be entering? How do you think we might go ahead and solve each of these steps? And then what kinds of things can we, what kind of systems can we set up to make sure that it's not an ad hoc trying to catch each step of this pipeline, and in fact, making sure it's robust along the whole way? Thank you.
Spectacular. And with 10 minutes left on the clock, I'd like to open it up for questions. And already some hands are up and microphones will be coming around. Soccer voice, go ahead. Meaning speak loudly. Yeah.
How early does your algorithm diagnose, and how did you validate it?
So I don't design the algorithms. This is the nice part of being the ethicist, is I get to come in and critique your algorithms. But I do think that the preclinical Alzheimer's disease, right, this idea that we start to have neuropathological changes that we can detect 10 or even 20 years before the onset of symptoms really just amps up the volume on all of the issues I raised, right? It's the question of, do people want to know that they're at risk for developing something that they have no symptoms of yet? Is there any way that we can intervene and do something for them now? Or is this just information that sort of looms over them and creates issues? They haven't given any consent for memory care because they're not in for that situation. So I think that it's the same set of issues and then just really amplified.
All right, having said that, of course, the your car's tracker that says like where you're driving, that's picking it up probably 5-10 years early because it's catching things like going too fast and other kinds of things. And most financial services industries are in the business of early diagnosis as well, whether they like it or not. So just to provoke you a bit. There were some other hands. Yeah. Go ahead.
Yeah, thank you for some fantastic talks. So a lot of the projects under this umbrella are looking at remote care, right? So looking at AI and technology in remote settings. So I wanted to zoom in on some of the problems that you've all mentioned, but in that specific context. So everything from the privacy implications of putting things like cameras in homes, useful in some contexts, but challenges emerge by using them. Training data sets. I mean, many of the technologies that are emerging in the market, you would like to use them immediately, but they're clearly not trained for older adults. And clearly there are problems, but if you don't put them in homes at that point, if you wait 3 years, it may be too late, right? So also issues around, ChatGPT and caregiving and trust issues. If you have ChatGPT and you synthesize video of a caregiver or audio of a caregiver, what are the implications there? So I'm just curious how you keep, how do we make, we want to use technology as and when it's available and understand how it's relevant in that context, but at the same time, many of the ethical questions are perhaps not clear even to us, right? I mean, it's not entirely obvious as to what the ethical challenges are and how to navigate that at this point, and what projects should do within a 1-year time frame to even think about those questions.
Want to take a crack at that? Maybe Irene too.
You said me.
Yeah.
Great. Yeah. I mean, step one, call your friendly neighborhood ethicist and have a conversation, right? Interdisciplinary research, right? Of course, I mean, one of the challenges I've had, so most of the spaces I work in are in biomedicine, right? I'm a geneticist, sort of biology is my native language. And lots of basic scientists, particularly folks in SynBio, like have never had any contact with human subjects research, and so don't think about it. But engineers really haven't, right? And like through no fault of their own, it's just not part of the training system that they went through, right? So there are challenges with sort of consciousness raising like even before you get to education, just getting folks to have the thought occur to them, like there might be some ethical issues here. What might I do not only to mitigate them, but to study them, right? Because I will say that ethicists, academic ethicists, like, yes, we like to consult and think through the problems with you, but also we really like to do research and ask questions about, what does happen if you have cameras or audio sensors in the home and it picks up on the fact that not the patient, but a family member is having issues of some kind, right? Like, what do we do with that information? How do family members think about that? How do we develop that, safely so that it's safe and effective and respects all the people in that home? Right.
Irene,
So I would.
Irene, did you want to add anything?
I think that, that's a great point. I would also encourage, this is probably, a longer term solution, thinking about how to integrate training in ethics into the education that we have about medical AI in general. I think these problems come from all kinds of different ways, and it's probably not so fun to get the ethics call at the very end and say, oh, here's what we did, we're about to submit for a grant or about to deploy and push send, tell us all the things that are wrong, and then we'll fix it before we push send. And I think maybe trying to integrate that as early as possible, either through bringing on someone on the team earlier, could reap a lot of benefit and maybe save some heartache at the very end.
I did not pay her to say that.
Emily, would you like to make a shameless plug for your core?
Good morning, Debra.
So seriously, there is a.
At Penn, we are fortunate to have an ethics and policy core as part of our collaboratory and are available for consultation.
Hi, good morning, Debra. I know we have had this conversation before. As an aging AI researcher, my feelings are hurt when everybody blames AI for bias. I'll tell you, because when I worry about AI becoming biased and uncontrollable is if it just goes on its own and collects data and self-supervised methods work so well that I'm deploying them everywhere, then I worry about that, right? Because right now, the humans who build AI systems are not ethical. So we need to look at that. I know at least a company does a big face recognition system. I'm not going to name it. 2 billion images from the web. Being lawsuits are there, etc. But the company has not folded. People are still buying that and using and so on. So we need to have some kind of a punishment, when people knowingly do unethical things with data, right? Because we collect data, we annotate them, and so forth. So I think the blame is on people who design, and so when we just say AI is doing this, I say, wait, the people who collect data, who annotate, who kind of should be more careful. So where do we put the blame? And I appreciate the comment made by the third speaker that sometimes subtle things show up. In our own face recognition system, we didn't use the gender, skin tone, but the deep features expressed them too much. And so it was biased. So we have to go and use adversarial training, knowledge distillation methods to reduce the bias. So that danger is there. So I'm just kind of torn. I agree, AI algorithms are not doing great, but it's like blaming a child because the parents didn't, do the proper rearing. Just a fun conversation I think we can have.
I'm not interested in laying blame. I'm interested in figuring out ways, as Irene talked about, looking at the entire pipeline of the development of these systems and figuring out how we can be thoughtful about how the ethics is playing out at each of these stages and really ensuring that the systems end up doing better than humans on issues like bias, as opposed to just reifying the biases that we know already exist.
I don't have totally a good vision courtesy of glare, but I think there's a,
Yeah, thanks, Jason. I have a question about waiver of consent for pragmatic clinical trials specifically and use of algorithms. I mean, let's go back in history. EHR or medical records would have blood pressure whenever you go in, weight whenever you go in, right? Now, let's say you're African-American and one time you visited and blood pressure got accounted for and you had hypertension and your primary care physician ignored it, right? You can be part of trials which can offer certain types of services, right? To probe the physician, to probe the patient, to probe the caregivers, right? Most of these types of trials or algorithmic trials, right? They get waivers of consent because they are done on thousands and hundreds of people. So where do we stand there? Like, what is the right thing to do? Because I actually manage a portfolio. That's why I'm asking today with the brightest mind in the room. But also I feel like, well, sometimes we know for certain what it is. And when do we take action and when we do not?
Do you want to start?
Emily, waivers of consent seems to be.
Yeah, so I am also part of the Impact Collaboratory, which is seeking to conduct pragmatic clinical trials to improve the lives of people living with dementia and their caregivers by addressing the same evidentiary gaps that I think motivate a lot of the work that's happening here. And you're absolutely right that a lot of those pragmatic trials take place with a waiver of informed consent. So when we think about research ethics paradigms traditionally, we think that informed consent is crucial. In fact, I think some people oversimplify research ethics to consent, but it's not the case that you can do anything you want just because somebody agrees that you can do it to them. But waivers of consent raise an interesting wrinkle in the situation because when certain conditions are met, we think that it's ethical and it's regulatorily permissible to conduct research without people being made aware of that research. So it has to be minimal risk, no more risk than happens in your daily life. It shouldn't adversely affect your rights and welfare to do this. It should be the case that it's not practicable to carry out the research without the waiver. So we're not waiving it when it's possible to get consent. It's really that we couldn't conduct socially valuable research without that waiver. So there's been a lot of research done to see about public acceptability of waivers. And I would say that a challenge there that arises is that most people don't like that idea. They like to have some sort of perspective informed consent. When you have time to really sit with people and educate them about the trade-offs, they often say, you know what, I can accept this. I can accept that this research is really important. One challenge that arises there is that not as much of this research has been done with minoritized populations, but we know that populations that are racialized often tend to actually say, in some of these cases, they find it less acceptable to conduct research with a waiver. And so some of the same populations, we think there are tremendous equity issues that we need to address, can also be more uncomfortable with the consent mechanisms we use to try to address those questions. So there's really a fundamental tension there. I think that all in all, I have many thoughts and would be happy to share some things elsewhere, but one of the things that comes up for me most is that we need to consult with people that are like the people that will be in the research. We need to be able to go to community members, people who are representative in these pragmatic trials, talk with them. What are your concerns? I think that sometimes, as the lived experience panel for the Impact Collaboratory really nicely surfaced, they have a very particular sense of what is risk to them, what are the outcomes that matter, how will this actually violate my rights and welfare, just to highlight a potent example for people who are living in a long-term care home. When research is conducted in your bedroom because somebody's mounted a camera there or proposes to do something, that is a very particular kind of privacy invasion and a very particular challenge to your welfare because you are living where the research is being conducted in a way that most of us can leave the clinic and we're no longer in the research milieu in the same ways. So people, I think, very reflexively like the idea of the waiver. It feels like it's very easy to conduct research that way because it gets rid of administrative hassle. But I think that there's really an ethical thicket and you have to think very carefully about the design of the research when justifying and using that. But at the same time, I wouldn't tell people to shy away from using waivers because they sometimes are really essential to conduct necessary research.
All right, last question.
This is Misha Pavel from Northeastern University. Really want to thank the panel, amazing panel. But I would like to ask a provocative question. I would propose that ethical bias is just an artifact of how we do what we call artificial intelligence at the moment. Because what we do is essentially take data that are collected in some way, maybe model driven, maybe not, and then we try to do very sophisticated categorization, classification, using machine learning that optimizes for averages, for expected values. Now, every time you have an individual or a disease that is not represented well, and I think Irene mentioned that, you will have bias. And unless we really start discovering the principles that underlie the mechanisms that cause diseases or whatever you're trying to do. So I was wondering what the response of any of the panelists would be to this.
In 1 minute.
I mean, you're completely right that the system exists and we build a model on it and we set it out into the world. I think if there's anything that I really wish people in this audience could take away is that all of these arbitrary choices are in fact choices. So we choose to collect the data. We could say this is insufficient data. We do not have enough to proceed. Scrap the whole project, spend the money that we would have spent on the rest of the project on just collecting data. And I think those are personal choices that we make along the way that are not to say we are blaming people necessarily for, to go back to an earlier point of, you're the one causing the bias, no, you're the one, but in fact, realizing that it is a process that we make very intentional choices consciously or unconsciously with the entire way, which result in these effects.
Well, what better way to end a panel on ethics than on the matter of choice? All right, thank you.